Hello, and welcome back to Of All People. I'm your host, Brock. Today, we're diving deep into a topic that affects millions of people worldwide, and something that every single healthcare professional needs to understand: kidney health. Whether you're a nurse, a physician, a respiratory therapist, or any other healthcare provider, the kidneys are central to everything you do in patient care. Now, I know that nephrology can sometimes feel like the forgotten specialty. Everyone gets excited about the heart, the brain, but the kidneys, they quietly do their job, filtering your blood, regulating your electrolytes, keeping you alive. But here's the thing: when the kidneys stop working, nothing else matters much. That's why we're here today. In the next hour, we're going to cover everything you need to know about kidney health and disease. We'll start with the basics: anatomy and physiology. Then we'll explore the 5 essential functions of healthy kidneys. We'll talk about clinical assessment, how you actually evaluate kidney function in your patients. We'll break down the stages of chronic kidney disease. We'll review common kidney disorders you'll encounter. And we're going to spend a significant time on the medications used in renal care. Because understanding how drugs work in the context of kidney disease is absolutely critical. Let's start with the basics. Your kidneys are about the size of a closed fist, maybe 4 inches long, 2 inches wide. There are 2 of them, one on each side of your spine, tucked up high in your abdomen, behind your abdominal organs. They're not in the front where the liver is. They're retroperitoneal, tucked away in the back. Each kidney weighs about 150 to 200 grams. Now, that might not sound like much, but consider this. Even though the kidneys make up less than 1% of your body weight, they receive about 20 to 25% of your cardiac output. That's 1/4 of the blood your heart pumps every single minute, going directly to your kidneys. That tells you something about their importance to your body. Now let's look at the structure. When you cut a kidney open, you see several regions. The outer layer is the cortex. That's where the glomeruli live. Cortex is Latin for tree bark, if that helps you remember anything. The little glomeruli are where the filtration actually happens. Deep inside is the medulla, which contains tubules and is arranged in pyramid-shaped structures. The medulla is Latin for marrow, like bone marrow is inside the bone. So cortex, tree bark, outside, medulla, marrow, inside. At the core is the renal pelvis, which is like a funnel that collects all the urine and funnels it down into the ureter, which then goes into the bladder. Now, the functional unit we need to understand is called the nephron. Each kidney has approximately 1 million nephrons. 1 million. And each one is a tiny, miraculous little filtering unit. The nephron has 2 main parts. First, the renal corpuscle, which consists of the glomerulus, that's the capillary bed where the filtration happens, surrounded by the Bowman's capsule, which catches the filtrate. And second is the renal tubule, this long, winding tube where reabsorption and secretion occur. The tubule includes the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and the collection duct. This tubular system is where the magic of the kidney really happens. There are 2 types of nephrons. The majority, about 85%, are cortical nephrons with shorter loops of Henle. Then there are juxtamedullary nephrons, about 15%, with much longer loops that extend deep into the medulla. These longer loops are specialized for concentrating urine. This is why, remember this part, the medulla, the inner part of the kidney, is absolutely essential for your ability to produce concentrated urine. That's clinical pearl number 1. If I had to teach you one thing, really one essential thing about the kidneys, it's their 5 primary functions. Understand these, and everything else about kidney disease will make sense. Your kidneys filter approximately 180 liters of blood every single day. That's almost 50 gallons. From that, they produce 1 to 2 liters of urine. Think about the selectivity, taking 180 liters down to less than 2 liters. That's the power of the kidney's filtering system. This filtration removes metabolic waste products like urea, creatinine, and uric acid. When the kidney fails to do this, these toxins build up, and that's when you get uremia, which is basically poisoning from accumulated uremic toxins. Patients with kidney failure become quite ill without dialysis. The glomerular filtration rate, or GFR, is the clinical gold standard we use to assess kidney function. Normal GFR is about 90 to 120 milliliters per minute per 1.73 meters squared. That's the amount of plasma being filtered by your kidneys every minute. The kidneys maintain your body's water and electrolyte balance with incredible precision. Think about it. Your sodium level, your potassium level, your calcium, phosphate, magnesium, all of these are controlled by selective reabsorption in the tubules. The proximal convoluted tubule reabsorbs glucose, amino acids, and some ions. The loop of Henle creates a concentration gradient through a countercurrent multiplier system, which is complicated. But the net result is that the tubular fluid becomes very concentrated in the medulla and very dilute in the cortex. This allows the collecting duct to make fine adjustments. Antidiuretic hormone, or ADH, also called vasopressin, controls how much water is reabsorbed in the collecting duct. When ADH levels are high, you reabsorb more water and your urine becomes concentrated. When ADH levels are low, you reabsorb less water, your urine becomes dilute, and you produce more urine. This is why you might urinate more when you're well hydrated. Now, this is really important for you as a healthcare provider. The kidneys are the blood pressure regulators. They do this through two mechanisms. First, by controlling fluid volume. The more fluid you have in your blood vessels, the higher your blood pressure. The kidneys control that by regulating sodium and water reabsorption. Second, through the renin-angiotensin-aldosterone system, or RAS. When blood pressure drops or blood sodium drops, special cells in the kidney called juxtaglomerular cells release enzymes renin into the bloodstream. Renin converts angiotensinogen to angiotensin 1. Then the lungs, specifically angiotensin converting enzyme, or ACE, converts angiotensin 1 to angiotensin 2. Angiotensin 2 is powerful. It causes vasoconstriction, the narrowing of blood vessels. It stimulates aldosterone release from the adrenal glands, which makes the collecting duct reabsorb more sodium and water. It increases ADH secretion, and all of this raises the blood pressure. This is why ACE inhibitors and ARB medications, which block this system, are important in managing kidney disease. More on that when we get to the pharmacology. Remember this because it's the foundation for understanding renal medications. The kidneys maintain your blood pH between 7.35 and 7.45. That's incredibly narrow. If your pH drops below 7.35, you're in metabolic acidosis. Above 7.45, it's metabolic alkalosis. Both are dangerous. The kidneys regulate pH through bicarb reabsorption in the proximal tubule and hydrogen ion secretion. The collecting duct has specialized cells called alpha intercalated cells that secrete hydrogen ions to get rid of acid. When you need more bicarbonate, beta intercalated cells secrete bicarbonate instead. This system is constantly fine-tuning your pH. In chronic kidney disease, this acid buffering system fails. Metabolic acidosis develops, and that actually accelerates kidney disease progression. This is why sodium bicarb supplementation is sometimes used in advanced CKD to buffer the acidosis. Finally, your kidneys produce hormones. The kidney is also an endocrine organ. First, erythropoietin, or EPO. This hormone stimulates your bone marrow to produce red blood cells. When kidney function declines, EPO production drops, the patients develop anemia. That's why we see severe anemia in kidney disease patients. Second, the kidneys activate vitamin D. Specifically, the proximal tubule cells convert calcidiol to calcitriol, the active form of vitamin D. This is crucial for calcium absorption in the intestines. In kidney disease, vitamin D activation declines, calcium absorption drops, and you develop problems with bone metabolism. Third, kidneys produce prostaglandins that help maintain renal blood flow and promote sodium excretion. NSAIDs block prostaglandin production, which is why NSAIDs are dangerous in kidney disease. They can precipitate acute kidney injury. These 5 functions, filtration, electrolyte balance, blood pressure regulation, acid-base balance, and endocrine function, these are everything. When you're assessing a kidney disease patient, ask yourself, which of these functions are we losing? That will guide your management. So, how do we actually assess kidney function in our patients? Let's talk about the lab tests and what they tell us. Serum creatinine. Creatinine is the breakdown product of muscle. Your muscles produce creatinine at a pretty constant rate, and the kidneys filter it out. A normal serum creatinine is between 0.6 and 1.2 milligrams per deciliter. When creatinine rises above that, it suggests that the kidneys aren't filtering as well. But here's the thing. Creatinine is affected by muscle mass, age, race, and other factors. A patient who is elderly or thin might have normal creatinine levels, but actually have significantly reduced kidney function. An athlete with lots of muscle mass might have slightly elevated creatinine, but normal kidney function. So creatinine is useful, but it's not perfect. The estimated glomerular filtration rate, or eGFR. This is the gold standard now. This is where we actually assess kidney function. Instead of just looking at serum creatinine alone, we use it in an equation that also accounts for age, race, and sex. The equation we use now is called the CKD-EPI equation, and it's much more accurate than older equations. The eGFR tells us what percentage of kidney function remains. A normal GFR is 90 or above. As eGFR declines, we classify patients into stages of chronic kidney disease, and we'll talk about those stages in just a moment. The eGFR is reported on every basic metabolic panel your patients get. It's essential that you know how to interpret it. Another lab is the blood urea nitrogen and urinalysis. BUN, or blood urea nitrogen, is another waste product from protein metabolism. Normal BUN is 7 to 20. Like creatinine, it rises when the kidneys aren't filtering well. But BUN is also affected by protein intake, dehydration, and gastrointestinal bleeding. The urinalysis is really informative. You're looking at the urine under a microscope. There are red blood cells suggesting glomerular bleeding, white blood cells suggesting infection or inflammation, casts, which are cellular casts that indicate kidney injury. Protein on the dipstick is normal and suggests a problem with the glomerular filter. Protein on the dipstick is abnormal and suggests a problem with the glomerular filter. A 24-hour urine collection quantifies protein excretion. Normal is less than 150 milligrams of protein per day. When patients have more than 3.5 grams of protein per day, that's nephrotic range proteinuria, and it indicates a serious glomerular disease. The medical community classifies chronic kidney disease into 5 stages based on eGFR. Let me walk you through each one. Stage 1, the eGFR greater than 90. This is normal or high kidney function. But if a patient is stage 1, The eGFR is greater than 90. This is normal or high kidney function. But if a patient is in stage 1, it means we've detected some evidence of kidney disease, maybe proteinuria or hematuria, or imaging abnormalities. So even though their eGFR is normal, we're watching them. Our job here is to identify and address risk factors: blood pressure control, diabetes management, lifestyle modifications. Stage 2. The eGFR is 60 to 89. This is mildly decreased kidney function. Patients might not have any symptoms. Again, we're assessing progression and managing risk factors aggressively. ACE inhibitors and ARBs become important here if there's proteinuria. Stage 3. An eGFR 45 to 49. Mildly to moderately decreased function. Now we're really evaluating the kidney disease. We need to know, is this progression due to diabetes, hypertension, glomerulonephritis? What's the underlying cause? This is when we might refer to nephrology if we haven't already. Stage 3B. eGFR is 30 to 44. Moderately to severely decreased function. This is when we need to start preparing patients for renal replacement therapy, either dialysis or a transplant. We should be having conversations about vascular access. We're managing complications more aggressively. Stage 4. An eGFR of 15 to 29. This is severely decreased function. Patients need intensive management. We're preparing them for dialysis. We're managing anemia with medications. We're controlling phosphate and calcium to prevent bone disease. We're addressing cardiovascular risk. And then stage 5, the eGFR is less than 15. This is kidney failure. This is end-stage renal disease, or ESRD. Patients must be on dialysis or have received a transplant, or they're pursuing conservative care. This is where we're managing the complications of kidney failure. The staging system is your framework for understanding the kidney disease progression and guiding treatment intensity. Let's talk about the common kidney diseases you'll encounter in your clinical practice. Acute kidney injury is rapid loss of kidney function over hours to days. It's classified 3 ways: prerenal, meaning blood flow to the kidney is inadequate from shock or dehydration; intrinsic, meaning there's direct damage to the kidney tissue like acute tubular necrosis from ischemia or drugs; and post-renal, meaning obstruction of urine flow. The key with AKI is identifying the cause and fixing it quickly. Many cases of AKI are reversible if you act fast. Glomerulonephritis is inflammation of the glomeruli. Patients present with hematuria, or blood in the urine, proteinuria, and reduced GFR. The cause could be post-infectious like strep throat or autoimmune like lupus nephritis. Diagnosing requires a kidney biopsy. Treatment depends on the cause, but often involves immunosuppressive drugs. Nephrotic syndrome is characterized by the massive protein loss in the urine, more than 3.5 grams per day. Patients have low albumin, which means fluid leaks out of their blood vessels into the tissues, causing severe swelling, and they also develop high cholesterol. The most common cause in adults is membranous nephropathy or focal segmental glomerulosclerosis. Diagnosis, again, requires a biopsy. Polycystic kidney disease is an inherited condition, usually autosomal dominant. Patients develop countless cysts throughout their kidneys over time, and by middle age, they often have hypertension and progressive kidney dysfunction. There's no cure, but we can slow the progression with blood pressure control and managing complications. Diabetic nephropathy is the most common cause of end-stage kidney disease in developed countries. High blood sugar damages the glomerular filter over time. We prevent and slow progression through tight blood sugar control with blood pressure management, like ACE inhibitors or ARBs, and increasingly with SGLT2 inhibitors. Hypertensive nephrosclerosis comes from chronic, uncontrolled high blood pressure. The glomeruli harden and scar. Again, prevention and slowing progression comes through aggressive blood pressure control. Each of these conditions requires different management strategies. Your role is to recognize them and get patients to the right specialist if needed. This is going to be the biggest section. Now we get to pharmacology. This is crucial material. When you're managing a kidney disease patient, the medications you choose must account for their kidney function. Many drugs need dose adjustments. Some shouldn't be used at all in advanced kidney disease, and some have renal protective effects you'll want to leverage. Let's organize these drugs by class and cover what you need to know about each one for your clinical practice. Diuretics. Let's start with the diuretics because managing fluid overload is central to kidney disease care. Loop diuretics, like furosemide, bumetanide, and torsemide, are the heavy hitters. They work in the thick ascending limb of the loop of Henle and block sodium reabsorption. They're powerful. They can cause significant electrolyte depletion. With loop diuretics, you've got to monitor potassium closely. You're looking for muscle weakness, palpitations, signs of hypokalemia. You also need to watch for ototoxicity, especially with intravenous dosing, which is hearing loss or tinnitus. Furosemide is most commonly used. Bumetanide is more potent. 1 milligram of bumetanide equals about 40 milligrams of furosemide, and torsemide has a longer half-life, allowing once daily dosing. An important point to emphasize is that these work even in advanced kidney disease. In fact, as kidney function declines, loop diuretics become even more important for managing fluid overload because thiazides become less effective. Thiazide diuretics, like hydrochlorothiazide, chlorthalidone, metolazone, work in the distal convoluted tubule and are first line for hypertension. Hydrochlorothiazide, or HCTZ, is commonly used, but there's something important. Thiazides become less effective as kidney function declines. Once eGFR drops below 30, they lose their effectiveness. All thiazides can cause hypokalemia, hyperglycemia, and elevate uric acid. They're not appropriate for patients with gout. They can cause sexual dysfunction, but because they're so commonly used for hypertension, you need to be watching for these side effects. Metolazone is interesting. It's called a weak diuretic, but when combined with a loop diuretic, they work synergistically. If a patient isn't responding to loop diuretics alone, adding metolazone can unlock a diuretic response. This is a useful combination in resistant edema. Potassium-sparing diuretics, like spironolactone, amiloride, triamterene. Now, these are different. Instead of causing potassium loss, they preserve potassium. That sounds good, but it's also dangerous. Spironolactone is an aldosterone antagonist. It blocks aldosterone receptors in the collecting duct, preventing sodium reabsorption and potassium loss. In heart failure, spironolactone is shown to reduce mortality, but you must monitor potassium closely. If potassium rises above 5.5, don't use it. And watch for gynecomastia, which is breast tissue enlargement. It's common and bothersome. Amiloride and triamterene work differently. They directly block the sodium channels in the collecting duct. Same problem though, hyperkalemia risk. These are typically used in combinations with loop or thiazide diuretics to prevent hypokalemia. Not alone, the combination allows the other diuretic to lower potassium while this one tries to raise it. They kind of balance each other out. Something that can cause dangerous hyperkalemia is using an ACE inhibitor plus a potassium sparing diuretic plus NSAIDs altogether. If you have to use potassium sparing agents, avoid the other two. This is critical. Osmotic diuretics. Mannitol. Mannitol is used acutely, usually in hospital settings, to prevent contrast induced acute kidney injury or to reduce intracranial pressure. It works by osmotically drawing fluid into the urine. It's given intravenously only. The concern is that it can cause severe hypernatremia and dehydration if you're not careful. ACE inhibitors and angiotensin II receptor blockers. Let me tell you something important. ACE inhibitors and ARBs are not just blood pressure medications. They're renal protective. They slow the progression of kidney disease. They reduce proteinuria, and in many ways, they're the foundation of kidney disease management. Remember the renin, angiotensin, aldosterone system we talked about earlier, or the RAS? These drugs block that system. ACE inhibitors block the angiotensin converting enzyme that converts angiotensin 1 to angiotensin 2. ARBs block the AT1 receptor where angiotensin 2 acts. The net result is vasodilation of the afferent arteriole, reduced glomerular pressure, reduced proteinuria, and slower decline in kidney function. ACE inhibitors like lisinopril, enalapril, and ramipril all work similarly. Common side effects: a dry, persistent cough in about 10 to 20% of patients. It's annoying, but harmless. More serious but rare: angioedema, severe swelling of the lips, tongue, and airway. If a patient develops angioedema, stop the ACE inhibitor immediately. ARBs like losartan, valsartan, and irbesartan work the same way but don't cause a cough. If a patient can't tolerate an ACE inhibitor due to cough, switch to an ARB. Both ACE1 and ARB can worsen kidney function acutely if an eGFR is already low or if a patient has bilateral renal artery stenosis. You also see hyperkalemia. Monitor potassium at baseline and 1 to 2 weeks after starting. And watch the creatinine. A small rise is expected, but if it jumps more than 30%, stop the medication. The bottom line is, for most kidney disease patients, an ACE inhibitor or ARB should be a fundamental part of their regimen. That's why we taught you the RAS system, because these drugs are that important. In advanced kidney disease, phosphate accumulates, the kidneys can't excrete it, and that excess phosphate triggers parathyroid hormone elevation, leading to bone disease and vascular calcification. Phosphate binders are medications taken with food that bind dietary phosphate in the gut, preventing absorption. Sevelamer is a non-absorbed polymer. It doesn't raise calcium levels, which is an advantage for some patients. You give it with meals, and it binds phosphate so it passes through without being absorbed. Calcium acetate is older. It provides some calcium supplementation too. The risk is hypercalcemia. Lanthanum carbonate is a rare earth element that binds phosphate. You chew the tablets, it doesn't raise calcium, and with all the phosphate binders, you have to monitor serum phosphate and calcium levels. The goal is to keep phosphate less than 5.5 milligrams per deciliter and to keep calcium normal. And don't forget, binders must be taken with meals to work effectively. Patients who skip doses also won't see benefits. Erythropoiesis stimulating agents, or ESAs, for anemia. Kidney disease patients develop severe anemia because the kidneys aren't producing enough erythropoietin, or EPO. Epoetin alpha and darbepoetin alpha are recombinant EPO products that stimulate red blood cell production. Epoetin is given 3 times a week, usually intravenously or subcutaneously. Darbepoetin is longer acting, allowing once weekly or every 2 weeks dosing. But here's a critical: you want hemoglobin between 10 and 11.5 grams per deciliter, not higher. If your hemoglobin goes above 12, the risk of blood clots, stroke, and heart attack goes up. So you're aiming for the lower end of normal, not trying to completely normalize hemoglobin. Before starting ESAs, check iron stores. The body needs iron to make hemoglobin. If iron is depleted, ESA will not work. You might need IV iron supplementation. Also, Monitor blood pressure. These agents can raise the BP and watch vascular access. If a patient on ESAs has a fistula or graft thrombosis, that's an emergency. In kidney disease, vitamin D activation fails, calcium drops, and phosphate rises. The parathyroid gland responds by producing excess PTH, secondary hyperparathyroidism. This causes bone disease and calcification of blood vessels. Calcitriol is the active form of vitamin D. It increases intestinal calcium absorption. The risk is hypercalcemia, so you monitor calcium closely. Paracalcitrol is a newer vitamin D analog that suppresses PTH better with less risk of hypercalcemia. It's often preferred in advanced CKD. With both, you're managing secondary hyperparathyroidism, trying to keep PTH in the right range, which varies by CKD stage, and you're also keeping serum calcium and phosphate normalized. It is a balancing act, as is pretty much everything in pharmacology. Sodium bicarbonate supplements buffer metabolic acidosis, common in CKD. You give it orally, and it helps bring the serum HCO3 level up. Calcium gluconate is used acutely for severe symptomatic hypocalcemia or in the emergency treatment of life threatening hyperkalemia. You stabilize the heart electrically, then treat the cause of the high potassium. Sodium polystyrene sulfonate, or KXLate, is an older medication that binds potassium in the colon and removes it through bowel movements. It works slowly over several hours. Newer alternative is Patiromer, which is more selective for potassium. Both are used when you need to lower potassium gradually. These agents are part of the overall strategy to manage the electrolyte chaos of advanced kidney disease. Some other agents that we use are allopurinol and cinacalcet. Allopurinol reduces uric acid production. In kidney disease, uric acid levels rise, increasing gout risk. Allopurinol prevents gout and reduces the risk of urate crystal-induced acute kidney injuries. Cinacalcet is calcimimetic. It makes the parathyroid gland more sensitive to calcium, suppresses PTH production, and is used in severe secondary hyperparathyroidism when other measures aren't sufficient. Okay, let me leave you with some clinical pearls. These are things that will help you in your daily clinical practice. Pearl 1. Always check renal dosing. Many medications need adjustment in kidney disease. Some should be avoided entirely. Make it a habit. Every patient, every medication, ask, does this need renal dosing? Pearl 2. Watch the potassium. The combination of ACE inhibitor, potassium-sparing diuretics, and NSAIDs is dangerous. Check potassium regularly on these drugs. Pearl 3. Proteinuria is modifiable. Reducing proteinuria through ACE1 or ARB therapy, blood pressure control, and dietary protein restriction slows CKD progression. It's a marker of disease progress and a target of treatment. Pearl 4. Listen to your patients about side effects. If an ACE inhibitor causes cough, switch to an ARB. If sexual dysfunction occurs, there are alternatives. Non-adherence because of side effects is a bigger problem than most other issues. Pearl 5. Prepare for renal replacement therapy early. When EGFR gets to 20, start discussing dialysis and transplant options. Time for vascular access maturation or evaluation for transplant is precious. Pearl 6. Kidney disease is cardiovascular disease. Your CKD patient is at extremely high risk for MI and stroke. Manage lipids, blood pressure, and lifestyle aggressively. Pearl 7. Collaborate with nephrology. Don't hesitate to refer. Nephrologists bring specialized expertise that can dramatically impact outcomes, especially in complex cases or as disease advances. Well, that's what we've covered today. From the anatomy of the nephron to the 5 essential kidney functions, from assessing kidney disease to understanding the medications that manage it, the kidney is one of the body's most remarkable organs, incredibly complex, but also very understandable if you break it down systematically. Now, whether you're going to take this knowledge directly into your clinical practice or you're studying for an exam or certification, I hope you're realizing that understanding the kidney changes how you see patient care. Every fluid balance issue, every medication, every electrolyte abnormality, it all connects back to kidney function. If you found this episode helpful, please subscribe so you don't miss future episodes. Leave me a review. That actually helps me reach more healthcare professionals and kind of helps me, tailor these episodes to what you guys really want to hear, what you really need to hear, things like that. And last of all, please share this with your colleagues who might benefit. Thank you so much for joining me today. I'm Brock. This is Of All People. I'll see you next time.